This is the continuation of our basic EKG interpretation presentation. Okay, let's now talk about sinus pause. Another name for this is sinus arrest. Okay, you can see here, let me get my little pointer going on here. We have a P wave, QRS-T, P, QRS-T, P, QRS-T, P, QRS-T, and then we wait and wait. There is a pause before we see the next P, QRS-T. Okay, so this area here, where there is no electrical conduction going on, is referred to as a sinus pause. So all the components of this heartbeat, the P wave, the QRS, and the T, are all normal. They're all present and normal. And the rhythm, the underlying rhythm, the R to R, appears to be the same. So the rhythm marches out. We call it a regular rhythm. However, right here, there is an interruption in the conduction. In other words, that SA node has not caused atrial contraction. Okay? The SA node has not fired. It has not caused or resulted in the atria contracting. Okay, and then of course followed by a QRS. Nothing is going on here. So it's very important when this occurs is that we notify the physician, right? And the physician is going to ask, well, how long was the pause? So before you call the physician, you need to determine how long the pause was. So we can easily do that simply here by counting the number of large boxes. 3, 4, 5, 6, 7, 8, 9, 10. And remember, each large box is 0.2. So 10 times 0.2 would give you 2 seconds. That would be a 2-second pause. Okay? And you would want to have that information before you put the call out to the doctor. The next question they're probably going to ask you is if the patient is symptomatic. And so you would have to know, you would have to have done an assessment on your patient to see if they are symptomatic as a result of this pause in their heartbeat. Okay? Sinus pauses may occur in people with healthy hearts, but it also can occur in patients who've had heart attacks, patients that have myocarditis, and even patients who have become digoxin toxic. Okay? Occasionally, you will see some little beats in that pause, and that's because the SA node is not firing, so some other ectopic area has decided to initiate an impulse. And so we can sometimes see a little blip in that area, but those beats that appear to be beats are not true heartbeats that are efficient and affecting any adequate perfusion. Okay. The treatment of this dysrhythmia, sinus pause, depends on the underlying cause. If the cause is due to increased vagal tone and the patient is symptomatic, then we can use atropine for that to increase the heart rate. So remember, atropine can be used with a sinus bradycardia, especially if they're symptomatic, but it can also be used for patients who have sinus pauses. That would be a very appropriate medication to prescribe to get that heart rate up and going. Okay, now let's talk about atrial fibrillation. This is quite a complex cardiac arrhythmia, and for that reason I've given you a supplemental article to read called Oh My Quivering Heart. I would like you to read that for additional information and helps explain a lot of the treatment decisions when a patient has atrial fibrillation. Okay, so atrial fibrillation is the most common sustained cardiac arrhythmia. Atrial fibrillation increases the risk of hemodynamic impairment and thromboembolic events. It may occur paroxysmally, but it often becomes chronic. Signs of acute atrial fibrillation are hypotension, myocardial ischemia, decreased perfusion of the vital organs, and acute congestive heart failure. Chronic atrial fibrillation increases the risk of atrial wall thrombus and embolus. Some conditions associated with atrial fibrillation include mitral stenosis, lung disease, heart disease, sepsis, hyperthyroidism, and cardiac surgery. Especially would like you to remember the mitral valve stenosis as being particularly associated with this condition, atrial fibrillation. Now note the baseline of this rhythm here. It's very wavy. It's described as chaotic. Sometimes you might be tempted to say, oh, there's a P wave, but these are not P waves. There are no P waves here. Okay, why? Because the atria are not contracting in a synchronous fashion. They're not all in sync with each other. Instead, the atria are fibrillating. They are quivering. And that's why we have this chaotic electrical activity here in the baseline. Okay, so no P waves. Now let's look at the R to R. Do they march out? Is this a regular rhythm? Well, clearly this R to R duration is different than this one. And actually, they're all different from each other. So this does not march out. And this is your classic example of an irregular rhythm. As we said earlier, this is the most common irregular rhythm. We see it frequently. Okay. In fact, there is no repetition of pattern when a patient has atrial fibrillation. So this is characteristically called an irregular rhythm, okay? Irregularly irregular rhythm. But what's nice about this picture, it shows you the quivering motion within the atria. And that stagnant blood, that stasis that results here, leads the patient to make clots, okay? And those clots, the dangerous part about this is that those clots can become dislodged and then travel. And the path that they travel, of course, will be different depending on which atria they were formed in. If you see here in the right atria, we have blood clots that could flow into the right ventricle and then to the pulmonary artery and to the lungs. And then on the left side, the left atria, when we have clots that form here, they would go to the left ventricle and then up through the aorta to the upper body. They could cause strokes and could cause infarctions anywhere in the body. But frequently they do go right up to the head and cause strokes. So the danger with this condition, now people can live with AFib. They do all the time. We have tons of people living with AFib. What they are at risk of is passing a clot or having an embolus that travels. So they are at risk of pulmonary emboli and they are at risk of strokes. Okay. So how do these people live? What do they need to be on? What kind of medication? Well, as you might have guessed, If the risk is forming clots, then we need to give them something to prevent them from forming clots. And we do that with Coumadin. For the most part, these patients are on Coumadin, which means, again, that we have to monitor their PT/INR to see if it's in the therapeutic range, meaning that they won't make clots, new clots. They shouldn't form new clots, and help to prevent the formation of clots and emboli. Okay. So yes, they can live just fine. If you have a chronic AFib and they're not symptomatic, then they can just live on Coumadin to prevent the formation of clots. However, let's remind ourselves, when people are on Coumadin, they are also at risk of bleeding now. So that's why we have to monitor those PT/INR levels. So here is information about atrial fibrillation. And there you go, there's a misspelling on that slide. I just noticed it today. So atrial fibrillation, there's no P wave. The baseline is seen as wavy. Generally, the QRS is normal. That's not a problem. And the rhythm is described as being irregularly irregular. Okay, that's the hallmark of this dysrhythmia. Oh, look at the atrial rate. That's kind of, actually it's quite stunning that if you can imagine that the atria have between 400 and 650 beats per minute. Okay, so you can see that it's just quivering. It's no effective contraction moving the blood along. So that's a problem. So what are the symptoms when our patients have AFib? Well, first of all, let's say that you can have AFib and not have any symptoms, and especially a chronic AFib. But acute AFib may be associated with symptoms, and those symptoms would include things like heart palpitations. That means they feel their heart beating very fast or hard within their chest. They could have chest pain. They could have dyspnea, fatigue, lightheadedness, and syncope. This is characteristically how they present. Oftentimes they are told that if they are having palpitations and they feel any of these symptoms, then they're to go to the emergency room right away. And there we will treat them for their AFib. Because if they have these symptoms, they are symptomatic. Okay, they are hemodynamically compromised. That's why they have these symptoms. So we would want to treat them in the emergency room and get them out of this arrhythmia if at all possible. Okay? The treatment of AFib is not necessarily simple. It's not just one treatment option for all patients. Things will vary, but one thing is for sure, that if the AFib is very fast, and we're talking here about the ventricular rate associated with the AFib, we are going to want to control the rate. We want to get the rate down below 100. When the heart rate is greater than 100, we say that it is uncontrolled. If it's below 100, then it's considered controlled. The newer terminology that we use in the hospital for uncontrolled AFib is atrial fibrillation with a rapid ventricular rate. So what you will see is AFib with RVR. Atrial fibrillation with a rapid ventricular rate is the same thing as a uncontrolled AFib with a heart rate greater than 100. Okay. Another thing that we will look at is antithrombotic therapy. And by that, we mean Coumadin generally. So they're going to be on a medication that will help them prevent the formation of clots. Now, the next thing we want to do is to correct the rhythm. We would love to be able to change their rhythm back to a normal sinus rhythm. And we can do that in different ways. One way that we can do that is by giving them an antiarrhythmic medication. We have a classification of drugs which are called antiarrhythmics, and sometimes those are effective in correcting the rhythm. However, sometimes that alone is not going to work. And so we have to we try these things, and then if that doesn't work, then we have to do some other type of treatment to change that rhythm to a normal sinus rhythm. The way that we slow the ventricular rate when it's fast is to increase that refractory period as the impulse is going through the AV node. Remember how there is normally a delay there at the AV node? Well, we can increase the amount of time of that delay or refractory period and slow down the ventricular rate. And we do that through the use of drugs such as are listed here. All three of these drugs could be used: digoxin, beta blockers, and calcium channel blockers. Just from personal experience, what you will see in the hospital most often is a calcium channel blocker, in particular Cardizem. Cardizem is a popular calcium channel blocker used in our atrial fibrillation patients with rapid ventricular rate. So Cardizem is excellent at slowing down the ventricular rate. And then sometimes if that doesn't work, they might put them on a beta blocker. And I've seen patients in the hospital on beta blockers that have AFib that we're trying to slow down their rate. So we see all of those drugs. Now, it may come to the point that we need to cardiovert the patient. That means that we have to do something a little more beyond giving antiarrhythmic medications. So we can do something called a chemical cardioversion or perhaps an electrical cardioversion. Both of these techniques are used in the hospital to convert patients from atrial fibrillation into a normal sinus rhythm. In this picture here, we see an electrical cardioversion where the patient has pads placed on the front and the back, and then energy is delivered. So we can basically shock them. So that's what you see in this picture, but I want to mention here about the chemical cardioversion. You may want to write this word down. This is when we do IV push medication. It's called adenosine, Adenosine. Adenosine is a chemical that we can inject intravenously, and it has the effect of cardioverting the patient's rhythm. Here we see a picture of an electrical cardioversion. On the left, you'll see that the heart rhythm is atrial fibrillation. The baseline is wavy. These are not P waves. So everything looks, this is irregular and clearly atrial fibrillation. It's very fast. If you counted the rate, if you were able to count it, it would be very fast. And what else was I going to say about it? And irregular. Well, we already mentioned that. Okay. So what we do here, we have those pads on the patient's chest and back, and we're going to deliver a shock. And this is what you see on the EKG tracing when you deliver joules, a shock here. And then what we see following it is that the patient begins, his heart rate rhythm begins to be P, QRS, T, P, QRS, T. And then we see that this is a normal sinus rhythm. Okay, so there is a P wave in front of every QRS, and then it is certainly broke this atrial fibrillation that was going on. So we get the heart back to a normal rhythm. The next rhythm we'll talk about, or arrhythmia, is atrial flutter. Again, we have a very fast atrial rate, 250 to 350 beats per minute. So the ventricles, again, are not contracting, and we're not getting a P wave as a result. Okay, instead, we're getting these waves here. These waves are actually called F waves. F for flutter waves. Okay, they are not P waves. And we have this characteristic pattern, up and down like this. And that is sort of like the serrated edge of a knife, or even a saw, a manual saw that you may see used to cut through wood. So they refer to this as a sawtooth pattern. That's what we're observing here. There is also a ratio between atrial F waves and our QRS ventricular contractions, and they will usually count the number of F waves to every one ventricular contraction, and that's what you will see in the patient's chart. So if you happen to catch that the patient has a flutter with a 2-to-1 ratio, then you at least understand what that's saying. It means that there are 2 F waves for every 1 QRS, or ventricular contraction. Okay, I'm not going to ask you to count ratios. Sometimes it's 3-to-1, but 2-to-1 is the most common. Just understand that that's what it's referring to if you happen to see it. Now, this is an important point because students get confused about this. Atrial flutter is not irregular, okay? Atrial fibrillation is irregular. But generally, atrial flutter is regular. Look at the R to R. They are the same. It marches out. So this is most oftentimes a very regular rhythm. Okay. Let's talk about the symptoms for atrial flutter. Well, the symptoms are really just about the same as atrial fibrillation. So, if you can remember the symptoms for atrial fibrillation, we have the same symptoms for atrial flutter. Palpitations. They may feel their heart beating very strongly or rapidly in the chest. They can have chest pain, shortness of breath, lightheadedness, fatigue, and low blood pressure. All the very same symptoms as we see with AFib, our patients may become symptomatic. So how do we treat a flutter? Again, we are going to want to cardiovert these patients, okay? Of course, the treatment's going to depend on the level of hemodynamic compromise. Synchronized electrical cardioversion is often used if the patient is hypotensive, has ischemic chest pain, or has severe heart failure. Okay, next we're going to talk about premature ventricular contractions, or PVCs. Now, PVCs can occur in healthy hearts. For example, If you have an increase in circulating catecholamines, you can have PVCs. But PVCs also occur in diseased hearts and from drugs, drug toxicities such as digitalis toxicity. Treatment is required if PVCs are associated with an acute MI, or if they occur as couplets or a repeating pattern such as bigeminy or trigeminy. If they are multifocal or if they are frequent. By frequent, we mean more than 6 PVCs per minute. Let's look at these wide and bizarre complexes called PVCs. Okay, here let's go. Start at the beginning with our 6-second strip. We have a P, QRS, T, and then all of a sudden, before we get a normal T wave even, we have this huge wide and bizarre complex. So see where I'm circling this so that all of this is considered a PVC. We don't need to analyze it and take it apart. Just be able to circle it and recognize it as an early ventricular contraction. Following that, we see a compensatory pause, a little prolonged here before we get our next P, QRS, and then, once again, we have this early ventricular contraction, P, QRS, another one, oh my goodness, okay, and this continues because you see we have P, QRS, and I'm expecting to have a T wave, but instead I get an early ventricular contraction, okay? So what you should notice in this particular strip is that every other beat is a PVC, okay? When you see every other beat is a PVC, we refer to that pattern as bigeminy. Okay, so this would be identified as a bigeminy. Every other beat, we'll say kind of normal PVC, kind of normal PVC, normal PVC, at least normal ventricular contraction PVC. Okay, so that pattern is can occur in diseased hearts and with some drug toxicities, and it is often associated with like heart attacks, and we would likely want to intervene when we see this kind of a pattern because it indicates that the heart is very irritable.